Why do we measure an ECG? Well, it's non-invasive. That's very useful. It gives us lots of good information about the electrical activity of the heart. So what is the heart rate? What we can, that's easy to measure in an ECG. What is the myocardium health like? Can we, so thinking about that, can we see abnormal pacemaker activity? Do we see arrhythmias? Do we say ectopic sites? So that just means, are we getting rhythms from the wrong place? Are we getting conduction disorders? We have got blockages somewhere? Have we got arrhythmias? So the heartbeat going out of sync. And do we have heart block? Have we got myocardial ischemia or a myocardial infarction? So you'd be thinking about a heart attack. These can all be detected very nicely in an ECG. And this is what your standard ECG will look like. You'll have a P wave, you'll have a QRS complex, you'll have a T wave, and then you'll go back to your P wave. So this whole complex here is one cycle, or one cardiac cycle. Okay, and we have various intervals. So we have a PR segment, an ST segment, a TP interval. And whilst it looks complicated, it's actually fairly simple if you understand what's happening in the heart to start with. So where the electrical activity starts, where it pauses, and where it goes. So that's what I want you to be thinking about now. I want you to think about what is happening in the heart. So where does it start? Oh, SA node. Where does it go? Throughout the atria. Where does it go to then? Oh, the AV node has a little bit of a pause before it goes to the bundle of His, the Purkinje, the left and right bundle branches, and the Purkinje fibers. I also want you to remember that we are going to be looking at electrical status. So what's happening at each point? The P wave. What does the PR segment refer to? And the QR, so we've got them measured there for you, and the QRS complex and the T wave. What do they tell you about depolarization in the heart and repolarization in the heart? So what is depolarizing and what is repolarizing? And just when we think about physiology, what is happening afterwards? So when you get depolarization of the atria, for example, straight away afterwards, you're going to get contraction of the atria. And then a little bit later, you get repolarization of the heart, of the atria, sorry, and therefore you get relaxation of the atria. And so it goes on. So I just want you to have a little bit of a think what's happening in each of these various segments, and we will then we'll go through it. So press pause, have a little bit of a think, and we shall go through it. Okay, so we're going to start at the very, very beginning. So remembering where it all starts, you've got that little diagram up in the top right-hand corner. We know it all starts in the sinoatrial node. Now, firing of the SA node does generate electrical activity, but not very much, okay? There is not enough electrical activity to reach the body surface, so we don't detect it in an ECG. So we don't see that, okay? So there is no wave. There is no wave or no depolarization or electrical event that we see for that purpose. So the first thing that happens is we get firing in the SA node, and then we get depolarization throughout the atria. That is your P wave, depolarization through the atria. You then have the PR segment. So from there to there, we've got depolarization throughout the atria, come to our AV node, and that, of course, is where we have our little pause. So that PR segment is our AV nodal delay. So a little bit of a pause to allow the electrical activity to finish. We then move on to the QRS complex. So atrial depolarization at the P, then AV nodal delay, PR, and then QRS. We get atrial repolarization, which is very small, but we get a lot of ventricular depolarization, which is massive. So that's your QRS complex. So just remember, QRS complex, ventricular depolarization, and hidden in there is your atrial repolarization. So as you might now start to imagine, we then move on to our T wave. If that was ventricular depolarization, the T wave is going to be ventricular repolarization. Our ST segment in between them, you can see there's no electrical activity there. So this is the time during which the ventricles are contracting and emptying. So ventricular QRS, ventricular depolarization, Then you get contraction, so this is when the ventricles are contracting and emptying, so there's no electrical activity going on. And then we come to repolarization of the ventricle, and then of course the TP interval is the time during which the ventricles are relaxing and filling, and again there's no electrical activity going on at that point. So that is the ECG in health. If you can do those crude few things that we just talked about, thinking about the P wave, the QRS complex, the T wave, and then a couple of the little intervals, what's happening at each of those points, that is what you need to know at this point. But what about ECG abnormalities? You should now know what's happening, or what a classic ECG looks like, the classic P, QRS, T. But we do see abnormal electrical patterns, and they're normally accompanied by abnormal contractile activity of the heart. I mean, that makes complete sense. Of course, you've got electrical activity leading to contraction and relaxation. Change the electrical activity, you change the contractile activity. So the main things that we can see abnormalities in rate. So here's your normal ECG. So we go along, we go P wave, look where my little arrow is, P, QRS, T, P, QRS, T. And you can see here, this is about 1 second. So you're getting about one beat per second, which is 60 beats per second, 60 beats per minute, sorry. But obviously in this case, you can see an abnormality, you can see it's much faster. So you're getting a lot more beats. You can still see the P there, the QRS, and then the T, but they're all much more bunched together. And that's because you have an increase in heart rate, which is your tachycardia, okay? And you can see the distances between the QRS complexes are much, much closer. And so you can measure an R to R interval, okay? Or you could measure a P to P interval. It doesn't really matter, but you tend to do R to R because it's a nice big and obvious peak in most cases. Okay, so that's your tachycardia, and of course a slower heart rate is bradycardia, and there are a variety of different causes for that. You can get abnormalities in rhythm. So again, here at the top is our normal one. So again, we got your P there, QRS, T, P, QRS, T. And you have when we're thinking about rhythms, we're looking about the regularity or the spacing between the ECGs. So does it look regular and does it look normal? And an arrhythmia is any variation from normal rhythm and sequence of excitation of the heart, as is indicated there. So what have we got in this little image? Well, we've got an atrial flutter. And what I'd like you to do is just have a little look at that atrial flutter before we talk about it. What can you see? Now, I know it says it there, but hopefully what you can see that the QRS, that's looking quite regular, okay? So it's regular, but rapid. We've got lots of P waves in there. So we've got P, QRS, T, P, 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 QRS, T. Okay, so we've got lots of P waves in there. So these are regular and rapid atrial depolarizations. And basically with an atrial flutter, the AV node is unable to keep up and only responds to 1 out of every 2 or 3 impulses. So what that means is only 1 in every 2 or 3 impulses from the SA node pass through to the AV node and then to the ventricles. And this is called a 2-to-1 or a 3-to-1 rhythm. Lots of things can cause this, okay? So it can be heart disease, high blood pressure, lung disease, can occur after cardiac surgery and also due to certain medications. So there are lots of causes, but the important thing to notice about it is that the atrial flutter is characterized by a regular and often rapid beating of the atria. And they typically occur at a faster rate than a normal heart rhythm. And then we've got an atrial fibrillation, and this is what you can see here. And if you're looking at this rhythm, it just doesn't look right at all, does it? You've got anyone can see that the QRS complexes have a different rhythm. They are irregular, and we have rapid atrial depolarization. So much so, if you're looking at that, you can see in the atrial flutter and a normal, you can see these nice P waves. Okay, in this, they're all fluttering, they're rapid, and they're all over the place. Okay. So what is actually happening in this case? Well, atrial fibrillation can occur due to various things. So again, age, high blood pressure, heart disease, alcohol, all manner of things can lead to atrial fibrillation, or AF. You might have heard the phrase before. And really what they all lead to is the electrical signals in the atria become chaotic and disorganized. And you can see that in the little flutters and the fibrillation, not flutters, the fibrillations that you're seeing in there. And basically the atria start to fibrillate or quiver instead of contracting effectively. So you get an irregular heartbeat. So the atrial fibrillation leads to an irregular and often rapid heartbeat. And it occurs when action potentials fire very, very rapidly within the pulmonary veins, for example, or in the atrium in a very chaotic manner. And it can result in, up to 400 to 600 beats per minute within the atria. And because this atrial rate is so fast and the action potential producers of low amplitude, P waves won't really be seen on the ECG in patients with an atrial fibrillation. And so that quivering or fibrillation of the atria reduces their ability to pump blood effectively into the ventricles, and as a result, blood may start to pool in the atria, leading to an increased risk of blood clots. And that's because you've got that stagnant blood sitting in the atria because the quivering or the very weak contractions don't allow blood to get into the ventricles. And if the clot dislodges and travels to the brain, it can lead to a stroke, obviously. So therefore, individuals with atrial fibrillation or AF are often prescribed anticoagulants to reduce the risk of blood clot formation. So what kind of symptoms might someone get? Well, if you're getting very rapid heart rate and it's all over the place, someone with the symptoms of AF may be palpitations, rapid, irregular heartbeat, fatigue, shortness of breath, dizziness, chest discomfort, anything that is well, pretty nasty, really. So those are some of the more common symptoms that people with an AF will get. So next we'll think about conduction abnormalities, and this really refers to any changes in conduction throughout the heart. Remembering what is happening in conduction, we're starting at the SA node, moving through the atria to the AV node where we get a pause, then through the bundle of His, the bundle branches, and the Purkinje fibers. That is your conduction pathway, and that's what's happening when we're looking at an ECG. And we already talked about heart block or AV block, and this is where you get defects in the conducting system such the atria beat normally, but the ventricles may not be stimulated. So then, in other words, they're not necessarily always contracting following atrial contraction. And the block can be to varying degrees. So in some forms, only the second or third impulses pass the ventricles. And in heart block, the atrial rate is normal, but ventricular rate is below normal because AV nodal delay has been increased. And there's a bit of AV and atrioventricular node dissociation. If we then move on to a bundle branch block, this is your bundle branches, remember? So they move from the conduction. Let's pretend SA node is normal, good. Through the atria is normal, AV node is normal, through the bundle of His is normal. Then we come to the left and the right bundle branches. And if we have a defect in the left or the right bundle branch, if it's in the left, it'll affect the left side of the heart. And if it's in the right, it'll affect the right. So example, if you've got fibrosis or scar tissue because of a previous MI in the left bundle branch, conduction through the left bundle branch will be slowed down. And that, therefore, is disrupting the normal sequence of electrical signals, leading to delayed activation of one of the ventricles. And this can result in asynchronous contraction of the ventricles, such that if the left bundle branch of the left isn't working properly, but the right is, the right will contract when it should, but the left doesn't. So you get asynchronous contraction, and that affects the heart's pumping activity. When we're thinking about that, what would happen to the width of the QRS complex? So if you're thinking about, here's the QRS complex, we'll go to the normal QRS complex, and that is about ventricular depolarization. If we're getting a delay, because it's all scarred and fibrotic tissue and the signal's going much slower through the ventricle, then that QRS widens. It becomes longer. It takes longer to get through there. And that can be a sign. So you'll see if you see a widened QRS complex, it suggests that conduction through the ventricle is going slower, so there may be a block somewhere in that pathway. Finally, we'll just talk about cardiac myopathies, and that includes ischemic, which is lack of blood supply, changes. So remembering what myocardial ischemia actually is, myocardial ischemia is inadequate delivery of oxygenated blood to the heart tissue. And that might be because a death of muscle tissue may occur when there's a blockage to a blood vessel supplying part of the heart with nutrients. And that is what an acute myocardial infarction actually is. And when we're thinking about the acute myocardial infarction, there are two main types of abnormalities that we kind of see. And those, and of course, an MI can lead to necrosis because we've blocked off blood supply, and therefore abnormal QRS complexes may be observed because we're altering conduction through the heart. So again, here's our normal rate and rhythm. And if someone has an MI, and this is called a STEMI, okay, and STEMI stands for ST, elevated myocardial infarction. So what you can see here is here's your P wave, here's your Q and R, and there's your S, and there's your T, and you can see they're elevated. So it's called a ST elevated MI, or a STEMI. And this is due to complete blockage of a coronary artery, and therefore in its resulting muscle damage. And actually, and that is detected by an ECG. You also get what's called a non-STEMI, and that is less serious. That's where you tend to only get a partial block of a coronary artery. So you might only get partial blockage or reduced blood flow. So the damage, you basically get damage to less of the heart. What else can you see when you have a heart attack? Well, of course, the muscle cells have died. And so when the muscle cells die, they release their components into the blood. And a key one that is detected now is troponin. So that's part of the complex, is the actin-myosin-troponin complex within the heart tissue. And you detect that in the blood. And if you detect large amounts of that in the blood, it suggests someone has had a heart attack. So, last couple of slides, I want you to have a look at these abnormalities, these ECGs, and just tell me what you think is happening. So have a look. The normal is there for you to look at. Then we've got first degree AV block. And I want you to just say, what can you actually see when you're looking at that ECG? And what might you predict as well? Okay, so let's have a look. If we're having a look at this AV block, what can we see? Well, we can see that the rate seems to be fairly similar. QRS, 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 same QRS. So we're seeing them at a very, very similar rate. Are we seeing a P wave? Normal, here's your P wave. Here is your normal P wave, here's your P wave as well. Are we seeing a QRS? Yes. Are we seeing a T wave? Yes, we are. So what difference can you really see? Has the heart, let's go through the options as we start to go them. Has the heart rate increased? Well, no, the heart rate hasn't increased. What about, has conduction speed through the SA node increased? So remembering what heart block or first degree AV block is, it's at the AV node, the atrioventricular node. So have we got any conduction speed differences through the SA node? No, we haven't, because it doesn't involve the SA node. Okay, so then we have a look at the next, or the third option. There is a delay between the P and the QRS waves. So let's have a look. Here's your P, okay, and here's your QRS. Compare it to normal. Yes, there is an increased delay there. So therefore that one is correct. Okay, so what this means is there's a delay in the conduction of electrical impulses from the atria, which is a P wave, to the ventricles, which is the QRS complex. And that delay usually occurs at the AV node. So it's an AV node delay. So therefore, yes, D is also correct. There is delay at the AV node. So that's what you would see in first degree AV block. Okay, so everything looks reasonably normal, but there is a delay between the P wave and the QRS complexes, and therefore the delay is at the AV node, hence the AV block. And so just a little thing, just some information for you. First degree heart block is relatively mild conduction abnormality, and actually many people don't notice any differences at all. I mean, why would you? Your ventricles are contracting normally, your atria are contracting, but there is a little bit of a delay there, and sometimes you'll miss a beat. Okay, so sometimes you won't always get that interaction between the atria and ventricles, but it's just a skipped beat. Very common in athletes to have that extended AV node delay. So now have a look at this one. This is complete heart block or third degree AV block. So remember the last one was looking at first degree AV block. This is third degree or complete AV block. And that means we have complete heart block. So the damage to the AV node is such that it no longer transmits signals from the atria to the ventricles. So in other words, the atria and ventricles are working independently of each other. So again, same thing. Have a look at the options there. Press pause and have a little bit of a think about what you can see and what you can't. Okay, so we'll go through these questions. So again, let's have a look at our normal. We've got a P wave, we've got a QRS complex, we've got a T wave. So in third degree or complete heart block, we still have some QRS complexes. We have some QRS complexes there. We've got our little P wave, so you can see a P wave, we've got a P wave, we've got a P wave, we've got a QRS there. Sorry, a T wave, so you've got QRS, T, P, 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 QRS, T, and then whatever else comes on. So are we seeing regular P intervals? Is that true or false? Yes, look at them. They are regular. Our atria and ventricles are functioning independently, leading to regular atrial contraction. So remember, the SA node is working absolutely fine. So we're getting SA node autorhythmicity, leading to atrial depolarization, 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 depolarization. But the atria and ventricles just aren't communicating with each other because the AV node is completely blocked. So, are we seeing normal atrial and ventricular rates? Well, that's obviously incorrect. The whole term heart block implies a disruption in the normal conduction of electrical impulses between the atria and ventricles. And so, therefore, this disruption often leads to lower ventricular rates compared to the atrial rates. So therefore, normal atrial and ventricular rates is not characteristic of third degree heart block. So atrial rate, absolutely fine. Ventricular rate, way too slow. And that's because the AV node isn't working. So now we're working at the bundle of His rate. Do we see narrow QRS complexes? And again, you can see just by looking at it that this is incorrect. Okay, third degree heart block typically results in this whole dissociation between the atrial and ventricular rhythms. And you tend to get, because the ventricular rhythm that originates below the AV node, you tend to get widened AV node, QRS complexes, and that's what you can see here. So, last one, do we see the presence of P waves that are not followed by QRSs? So P wave, P wave, P wave. There's no QRS coming after these at the appropriate place. So that is correct. The P waves are not always followed by QRS complexes. In fact, they're never followed in coordination with QRS complexes. So there's a lack of coordination between the atrial and ventricular contractions. And as a result, the P waves, which represent atrial depolarization, occur independently of QRS complexes. And in these patients, a pacemaker will often be required with heart block because you need to get those ventricular contraction rates going appropriately.